Good afternoon, everyone, and welcome to Code's Inner Circle Masterclass webinar. Circle of Dental Excellence, also known as Code, is a dental organization for all members of the dental community, including administrators, clinical team members, and educators. We provide frequent opportunities for education with monthly masterminds, the Inner Circle Masterclass webinars, and in-person events throughout the year that are also offered virtually. It is my pleasure today to introduce our guest speaker, Alyssa Mizenko. Alyssa is the driving force behind Zen Dental Support, an organization that has become a lifeline for practices looking to bridge the gap between clinical excellence and administrative sanity. Alyssa doesn't just understand dental billing, she understands the rhythm of a dental office. At Zen Dental Support, she and her team specialize in behind-the-scenes mastery, handling everything from complex claims and aging reports to the very topic we're diving into today: clinical documentation. She is an expert at helping doctors and teams audit-proof their charts so that the hard work you do at the chair is actually reflected in the reimbursements you receive. Alyssa, I'm thrilled to have you and your brain in the room today. Welcome to the Code Inner Circle webinar.
Thank you so much. I'm going to go ahead and do a quick share of my screen so that way everyone can see what's going on. Hello, everyone, and thank you, Laura, for that warm welcome. It was very, very, very nice of you. As Laura mentioned, today we're going to be talking about one of the most common pain points in dental offices, and that's insurance denials and documentation. So from periodontal maintenance to crowns and core buildups, my goal today is to walk you through what carriers look for, how to document correctly, and how to make sure your claims get paid the first time you submit them. So before we dive too far in, let me go ahead and just give a quick disclaimer that today's webinar is not about ADA or CDT coding. It is about reviewing clinical criteria and documentation considerations related to commonly billed dental procedures and areas where, quite frankly, I see it happen most frequently, where incomplete clinical support often results in claim denials or lost revenue. So real quick, clinical documentation and understanding clinical criteria is not just paperwork. A lot of people think that it is, that it just drags everything down. It's not busy work either. And it really is not optional anymore. We're at the point where it is the bridge between clinical excellence and the financial health of your practice. Every single day, providers perform treatment that they know is necessary. You diagnose disease, you see the bleeding, you see the bone loss, you see the fracture lines and the failing restorations. You are treating real conditions that impact your patient's overall health. And yet there is nothing more frustrating than delivering a service you know was essential, only to receive a denial a few weeks later stating not medically necessary. That frustration usually isn't about the insurance company alone, though sometimes it is. But it's about the disconnect, because in today's dental landscape, one rule stands above all else. If it's not documented, it didn't happen. So insurance carriers are not in your operatories. They don't see the inflammation. They don't see the probe that goes 6 millimeters deep. They don't feel the mobility, and they don't see the crack that runs some gingival. All they see is what's on paper. And what they are looking for, is consistency, and it's proof of true dental and medical necessity. They want to see the diagnosis before you do the treatment. They want to see the clinical findings tied directly to the procedure performed. And they want radiographic evidence, periodontal charting, and clinical notes that connect all of the dots. If we cannot clearly demonstrate the why behind why we did something, we create gaps. And those gaps lead to denials. And here's the cold, hard truth. When we fail to document properly, we're not just impacting revenue. We're weakening our clinical story. We're undermining our standard of care. And ultimately, we're doing a disservice to our patients because coverage challenges can delay or discourage necessary treatment. The truth is that strong documentation protects 3 different things. First, the patient. Second, the provider. And third, the practice. It supports quality care and it supports compliance. And yes, it supports reimbursement, which I know is one of the main reasons a lot of you are here today. But when clinical criteria and documentation are aligned, something really powerful happens. Denials decrease. Appeals become easier. Conversations with patients become clearer, and the entire team gains confidence. So today we're going to talk about how to make documentation intentional, not just templated fluff, not copy and paste notes, but meaningful, defensible, and aligned with payer guidelines. Because when your documentation tells the full clinical story, you don't just improve collections, you elevate the standard of care in your practice. So while clinical roles may really differ within a dental practice, understanding clinical criteria is essential for every team member. And I see this frequently. I see this very frequently with dental offices, that we think that clinical stays clinical with our clinical team, our dentists and our hygienists and our assistants, and that administrative stays administrative with our front office admin team members, our insurance coordinators, or our office managers. But the truth is, whether you communicate with patients, present treatment, create or submit claims, deliver care, clinical knowledge directly impacts the clarity, the confidence, and the trust in your practice. Strong understanding leads to better patient communication, stronger rapport, and increased case acceptance. And as insurance requirements continue to tighten, thorough clinical documentation and proper supporting evidence are now more critical than ever. We can no longer rely on minimal attachments or assumptions of coverage. So there was a period of time when you could submit for a scaling and root planing claim, and you could send in a pano and a simple perio chart, and that claim would get paid. And yes, there are still carriers who will pay the claim based on those simple attachments. But the majority of payers now are requiring more documentation. And one of the most significant trends in dental insurance today is the use of artificial intelligence, not only to just streamline verifications and enrollment, but to adjudicate claims as well. And as a result, submitting a clean claim on the first submission now is more critical than ever, because when you don't submit on the first claim, that claim gets denied. When that claim gets denied, it's already been reprocessed. So you can't just do a simple resubmission with more information. You need now to appeal. So we create a lot of administrative burden when we have to file claims more than once. My goal today is to share what I found to be a comprehensive overview of clinical criteria and documentation requirements across multiple dental insurance carriers based on common requests from payers like Delta Dental, United Healthcare, and Guardian. Okay, so we're going to start first with our first procedures, and those are going to be X-rays, which is a really hot button issue right now in our field. So there's been a lot of chatter since the ADA reissued their guidelines, and X-ray procedures are pretty serious to talk about right now. Radiographs, the most important thing to remember about radiographs is that they are diagnostic tools. They are not routine add-ons, and they are not automatic parts of a visit. They must be ordered and prescribed by a dentist for a clinical reason. Each radiograph prescription needs to be patient-specific, and it should be ordered after the treating dentist performs an exam. And no, that sequence is super, super critical. But let's talk about documentation, because this is where I often see a lot of practices trip up, because your clinical note needs to clearly state three things. First, who ordered the X-rays? Usually your dentist. Second, the diagnostic reason they were taken. Why did you order a PA? Was it to check on the decay of tooth number 19? What was the purpose of it? And then third, the doctor's interpretation of those images. Not just that they were taken, but what the doctor saw and how it impacted diagnosis or treatment planning. If that interpretation isn't documented from a payer standpoint, it's as if it didn't happen. And I have a strong suspicion, if you've been keeping up with all of the payers that are changing things and changing how they're processing X-rays, we're going to see even more insurance carriers flagging radiographs moving forward, specifically looking for those reasons. Who ordered the X-rays? Why were they taken? And what came from the X-ray? But here's another important distinction about X-rays. Radiographs taken as part of a procedure, for example, during endo or when seating a crown, are generally considered part of that procedure. They're not typically for diagnostic purposes, so they were taken to complete the procedure, so they're not typically payable in addition to. Finally, when you're filing claims for x-rays, you want to make sure that you always bill for what you do. If you take 2 bite wings, 3 periapicals, and a panoramic x-ray, then you should bill for 2 bite wings, 3 periapicals, and a panoramic x-ray. You did not take a full mouth series of images, an FMX. You took 2 bite wings, 3 PAs, and 1 pano. So you really want to make sure that you are documenting what you took, why you took it, what you saw, and then the specifics of what you took that should be billed to the carrier. The important thing here is that accuracy matters when it comes to x-rays. Specifics matters as well, and documentation always matters. As payer oversight continues, clarity in ordering, interpreting, and billing radiographs is going to be one of the biggest compliance safeguards that your practice can implement. And my own personal opinion, x-rays are one of the top 3 necessary attachments for procedures. So it's critical that they are of diagnostic quality. I'm going to repeat that again. It is critical your x-rays are of diagnostic quality. Fuzzy or unclear images, PAs that are cone cut, bite wings that don't show the bone level, they make it nearly impossible to get procedures paid. So if you take one thing away from today's training, please let it be this. Your x-rays must be diagnostic quality. So now that we've talked a little bit about radiographs and the importance of diagnostic intent and documentation, let's build on that a little, because the same principles apply, maybe even more critically, for periodontal procedures. Radiographs have just become a hot topic issue. But I bet if Laura took a poll right now on scaling and root planing, a lot of attendees would say that they've been struggling with getting scaling and root planing claims paid. These type of claims have been under the microscope for a while. Services like scaling and root planing and periodontal maintenances are some of the most frequently denied procedures. And if you want to know the reason why, what do you think I'm going to say? You're right. You said documentation. Just like x-rays, insurance carriers aren't paying for what we do. They're paying for what we can prove. So that means your chart must clearly tell the story. If the diagnosis isn't there, the procedure looks elective. If the clinical data isn't there, the procedure looks unsupported. And if the clinical note isn't clear, the claim becomes vulnerable. So let's walk through what periodontal documentation actually looks like and how to position your claims so they're far less likely to get paid the first time. So first and foremost, your clinical note must include your periodontitis staging and grading. This is huge. If you are not including staging and grading into your hygiene templates and your hygiene clinical notes, I encourage you after today's training to go to Google and search, and I'm going to show you on the next slide what this looks like, but search staging and grading of periodontitis. This is the gold star of documentation, okay? The majority of insurance carriers are looking for documentation that the patient presents with stage 2, stage 3, or stage 4 periodontitis, along with grade B or grade C progression in order to support procedures like scaling and root planing. And I see this is where I see a lot of confusion. And one of the most common questions I get from dentists, hygienists, and administrative teams is, what does that even mean? Or how are we to determine and grade in a way that supports our claim? And I think that that's a really fair question, because if you don't fully understand staging and grading, it becomes very difficult to document it clearly and confidently. The American Academy of Periodontology established the current classification system. Again, I'm going to show you that on the next slide. And it gives us a structured way to describe both the severity of the disease and the rate of progression. The staging tells us how severe the destruction is, whereas the grading tells us how quickly the disease is progressing and the patient's overall risk factors. When you document both clearly in your clinical note, you are doing more than satisfying insurance requirements. You are demonstrating a defensible, standardized diagnosis that aligns with nationally recognized guidelines. So let's break this down and take a look of what stage 1 through stage 4 really looks like. Again, if you are interested in this information, all you have to do is Google staging and grading periodontitis, and the very first thing that's going to come up in your search is going to be from the American Academy of Periodontology. And this is, again, this gold standard. So as we see, and let me reiterate, staging tells us again how severe the destruction is, how much attachment loss, bone loss, and the complexity what we're dealing with. So if we take a look at stage 2, our clinical attachment loss is 3 to 4 millimeters. Our radiographic bone loss is the coronal third, 15% to 33%. And we have maximum probing depths of 5 millimeters. As you can see, when you progress into stage 3, our clinical attachment loss changes to 5 millimeters. There's more tooth loss. The coronal third the radiographic bone loss extends to the middle third of the root and beyond. So you really need to you need to understand the stages so that way you can identify clearly what stage your patient is in so that can be reported. Additionally, there's grading. And the grading aims to indicate the rate, the periodontitis progression, the responsiveness to therapy, and the impact on the systemic health. So in this, we're looking at how quickly the disease is progressing. So if we're looking at grade A, there's no radiographic bone loss over the course of 5 years. They may be a non-smoker, or they may smoke less than 10 cigarettes a day. And all of that changes whether they're grade A, grade B, or grade C. Okay. Again, I encourage you, if this is new to you, new to your office, this is something that definitely you want to talk about as a team. So let's talk about attachments then with scaling root planing, because again, we have a lot of claims that tend to get denied due to lack of clinical necessity or lack of medical necessity. So on top of your staging and grading, you should always expect scrutiny with scaling and root planing claims. Carriers assume SRP must be clinically justified. So again, they're looking for that proof. So what does that proof look like? First and foremost, a full periodontal chart. Now I'm going to say that again, a full periodontal chart. That means 6-point probing depths, clinical attachment levels recorded, bleeding points, recession, furcation. It has to be a current periodontal x-ray, not from 3 years ago, but one current to the data service that you're working on. I see this happen a lot. We get into a rut where we're recording probing measurements on our perio charting, but we're not recording anything else. And that's not a complete perio chart when the insurance company receives that. So you really want to make sure that you have built into your schedule, built into the appointments, enough time for your hygienists to do full periodontal probing. Second, you want to include radiographs, right? So this is not new. A while ago, as I said, you used to be able to send in a simple perio chart and a pano, and that would be sufficient. These days, most carriers are requesting a full mouth series of x-rays, or they're looking for a pano with bite wings, whether that's for horizontal bite wings or vertical bite wings. That's typically what they're looking for. And again, this is really important because carriers want to see the radiographic evidence of the bone loss that correlates to your perio charting. So if your chart shows 5 to 6 millimeter pockets, but your radiographs show pristine bone levels, that disconnect is going to trigger a denial. Okay. Third, you want to have that documented periodontal diagnosis. And this is where your staging and grading comes back into play. Your notes should include something clear like generalized stage 3, grade B periodontitis. A diagnosis is not needs SRP or moderate perio. You want to be very specific and very clear with your diagnosis as it aligns with the American Academy of Periodontology in order to bulk up your documentation. And then fourth, as part of this is just good practice, not every claim needs a novel attached, but there are going to be instances where you need to expand in your clinical note and maybe write an additional narrative. Okay. Now, as a total disclaimer, let me state that narratives no longer exist in the dental world. The insurance companies are looking for direct screenshots of your clinical note. So your narrative is now part of your clinical note. But sometimes we have to maybe summarize in our clinical notes a little bit more clear of what's happened. So if there's complicating factors such as heavy subgingival calculus, inflammation, bleeding on probing, all of those things that we were typically reporting, you may need to specify that in your clinical note. And remember, if it's not in your clinical note, it didn't happen. So additionally, there are some additional things that I recommend putting as part of your clinical note because carriers are requesting them. One of those is anesthetic used. So how much anesthesia was your patient given before the start of the appointment? And then in addition, appointment length. What they're trying to do is they're preventing 4 quadrants of scaling and root planing being done in 60 minutes. So they want to see how long the appointment was to warrant that the treatment was actually in fact done. So be sure that you have all of those pieces as part of your clinical note. So that way, when it comes time to file your claim, it's very simple to attach your x-rays, attach your full charting periodontal chart, and then attach a copy of your clinical note that includes your staging, your grading, your anesthetic use, and your appointment length. That protects you against several different carriers who might be asking for different information. Okay. Here's something that's really important about scaling and root planing. The attachments should tell a consistent story. Your period chart, your radiographs, and your diagnosis must all align. And if the story doesn't add up, the claim becomes vulnerable. Okay? You want to ask yourself before you submit a claim, any claim at all, if I were to review this claim without any prior knowledge of the patient, would the documentation clearly justify the therapeutic treatment? If the answer is yes, then you are golden. But if the answer is maybe or probably not, then we need to tighten up the documentation before it leaves your office. So this naturally takes us into periodontal maintenance procedures. This is another service that is frequently denied, often due to misunderstandings about the procedure itself, or once again, insufficient documentation. One of the most important things to remember about periodontal maintenance is that it comes after periodontal therapy. After periodontal therapy. This means that the patient must have had a history of scaling and root planing, osteosurgery, or gingival flap surgery in order to be considered periodontal maintenance. If the patient hasn't had any one of these procedures, then they cannot be a periodontal maintenance patient. I see this happen a lot. We'll see a new patient that comes into the office and they clearly have periodontal disease. And the patient says, oh, I had that done years ago. So the patient says, so the hygienist says, okay, well, we'll notate it. We'll do a periodontal maintenance. But then we find out that the patient actually never had scaling and root planing. They just were on 3-month prophies. So all those perio maintenances get denied because they don't have history of scaling and root planing. During a maintenance visit, selective site scaling and root planing may be performed as needed to address areas where plaque or calculus has returned. Okay, and in short, periodontal maintenance is about protecting the results of treatment, preventing reoccurrence, and keeping gums healthy. So that's why it's really important that the patient have had the treatment done, and this is the follow-up. Keep in mind, a lot of carriers and payer policies can fluctuate about periodontal maintenance. Some pay every 3 months, some lump in frequencies with prophies, some require that your patient have active periodontal therapy within 24 months in order to pay for periodontal maintenance procedures. So because of this, it's essential to track the patient's treatment history. My recommendation is to include this directly into your clinical note. Patient presents for periodontal maintenance, patient periodontal therapy history, and then have a section right there for you to record when the patient's periodontal therapy was rendered. And if you're documenting it from the very beginning, from that patient's very first appointment, it just becomes part of the clinical record. So you're able to then take that information, review it, and add it to your next clinical record. Really makes it quite simple when we think about it. So you want to make sure the reason we document it in that clinical note is, again, because your clinical note is your narrative. So if it's recorded there, you can just take a direct screenshot of your clinical note and send that off to the insurance carriers. Attachment-wise, most carriers, again, are looking for that periodontal therapy history, and some even do request a 6-point perio chart. Now, a lot of carriers, there's some out there that you can submit a periodontal maintenance to, and they will pay them without asking for additional information. The question then comes back, though, if the perio maintenance procedure itself requires osteosurgery, what will happen if you ever are audited and they ask for that history? If the patient hasn't had those, then they don't qualify for a perio maintenance, and it could put you in a sticky situation. So as I always say, make sure you have your ducks in a row. Make sure your clinical note has all of your perio history, so that way you can just send it right out to the carriers. All right, I'm going to take a pause. I'm going to take a quick coffee sip. I don't know, I can't see any of the chats because I've got too many screens open. So Laura, if there's anything that you need me to slow down on, please let me know.
Oh, no. So I don't have any chats in there yet. Did you? Let me see. Where's the poll? No, looks like 50% of everyone participated. Do you kind of want to see like the gauge of where they are? Do you want to talk about that when we're all finished?
Yeah, let's do it when we're done. Yeah, I'll
Okay.
go.
I'll leave it open for those of you who haven't finished it yet. I'll leave it open. And then when we're done, before we get to the Q&A part, I'll kind of review where everybody is. Okay.
Great. Awesome. All right. So we're going to dive into some oral surgery procedures next, because this is the next area where I see that documentation and clinical guidelines tend to be a sticky situation. So first, let's talk extractions. Ooh, I'd love to know, I see everybody raise their hands, but if you've ever had a downgrade of an extraction, I'm sure you are frustrated. There is nothing more frustrating than billing for 5 surgical extractions and then them all coming back downgraded to a simple extraction, right? So we have to ask ourselves, what's the difference? Well, things have changed a little bit, and we want to make sure that you've got all this information. So a surgical extraction involves the removal of bone and or sectioning of the tooth, right? If your clinical note does not include this detail, it is almost guaranteed that the procedure will be downgraded to a basic extraction. Again, I'm gonna reiterate that. Surgical extraction requires the removal of bone and or sectioning of the tooth, and that includes the elevation of flap if indicated. There is a period of time where we thought that if you did sutures, that was enough to warrant a surgical extraction. That is not the case. You must have removed bone or sectioned the tooth in order for an extraction to be considered a surgical extraction. And you need to have your diagnosis. Again, here we are with recording. Why did we do the extraction? Was the tooth hopeless? Was the tooth fractured? What was the reason? Patient was in pain. You want to expand on that diagnosis, so that way when your carrier or if you're ever again go through an audit, all of that information is documented in your clinical note that keeps you nice and protected. Okay. Finally, your diagnosis include what steps you took to determine the diagnosis. That often is missed. We don't explain, and we'll talk about that when we get to restorative procedures a little bit more. So when filing your claim for extractions, you want to include a direct screenshot again of your clinical note. Why? Your clinical note is your narrative. So it summarizes the service that was performed. That's where it's going to indicate that you removed bone or sectioned the tooth. And it clearly states your diagnosis as to why you did the procedure. Supporting X-ray documentation, such as a pano or a PA, depending on how many teeth you're extracting, is typically sufficient to ensure that the claim gets paid. I have seen carriers accept a pano. I have seen carriers want the PA. You have to ask yourself your standard of care documentation. In my office, we had a rule that X-rays generally needed to be within 60 days, but with guidelines and ADA and the ADA pushing out, saying what's recommended and we want to expose the least as possible, you need to make the determination how good the X-ray is and how old the X-ray is. But usually at least a panel or a PA is enough to submit along with that clinical note. But again, that clinical note, more times than not, I see extractions to get downgraded from a surgical extraction to a simple extraction because the clinical note wasn't sent and because the clinical note doesn't state specifically that bone was removed or that the tooth was sectioned. And again, you're only recording that if you're doing a surgical extraction. I think that speaks for itself. We're not just billing surgical extractions when we do simple extractions. Bill for what you do. So let's touch then on our last oral surgery procedure, which is bone grafting. There is lots of different kinds of bone grafting procedures. Some are done on naturally retained teeth for periodontal reasons. Others are done at the time of extraction. Still others are done at the time of implant placement. You want to make sure that you're using the right procedure for the right scenario. Today, I'm going to focus on bone grafting done at the time of extraction. So when providing this service, your clinical note should clearly include the diagnosis. Here we are again talking about that diagnosis, and the diagnosis is the why. Why was the bone grafting necessary? If you're planning for a future restoration, such as a bridge or an implant, it's helpful to include the estimated date for that restoration. So your clinical note might include something like this. Bone grafting was necessary to preserve the ridge, to prepare a site for implant placement, future implant placement planned in 3 to 4 months. Okay, something like that is typically sufficient. It indicates the plan. We're going to talk a little bit later about SOAP notes and the importance of SOAP notes. And part of that SOAP note is the plan. So by telling in your clinical story, in your clinical note, that whole process from start to finish, you're covering all your bases. For documentation, you want to include a pano or a full mouth series of x-rays to show the full arch. I've also seen CBCTs used as a way to document. And as always, a copy of your clinical note with your diagnosis. Because that is going to be huge in making sure that the insurance company has all the necessary information. Okay. So this brings us to the biggest hot topic of denied claims that I think I've ever seen. We are going to talk restorative procedures next, including crowns and core buildups, and quite possibly the most frustrating in our industry right now. If I could ask for a raise of hands, I bet you every single person on this call today would probably raise their hand saying that they have seen a single tooth crown denied for medical necessity. So let's talk about what you actually need to have for single tooth crowns. So as I said, huge pain point, and you know what it usually comes down to. If you said documentation, you're right. Each carrier has very, very specific requirements to pay for crowns, and there are a lot of factors at play. Waiting periods, frequency limitations, and then the clinical criteria on top. Sometimes it feels almost impossible to get these claims paid. But here's the good news. If your documentation is thorough, and if your clinical note tells the full story, then you're in great shape. Your note should answer the critical question, why was a crown necessary over a simple filling? Okay, why was a crown necessary over a simple filling? If your clinical note just says needs crown or carries, that's not enough, right? Answer the question diligently and completely, and you'll see a big difference in your crown payments. So let's talk about some of the diagnosis that carriers typically accept. So things like extensive caries or tooth fractures, replacing large defective restorations, complete cusp fractures, endo-treated. But if it's an endo treated and you didn't do the endo, make sure you have recorded the date that the endo was treated, especially if you're going to be doing a post and core in there, because most carriers will want to know the date the root canal was originally done. And then finally, cracked tooth syndrome with testing. I see this happen a lot too. Doctors will record and say patient diagnosis, cracked tooth syndrome. But carriers want to see what steps did you take to determine that the patient had cracked tooth syndrome, okay? Payers also pay attention to the prognosis of the crown. Patients with untreated or uncontrolled periodontal disease, untreated pathology, or unfavorable crown to root ratios are often flagged, which can lead to denials and create a large administrative burden for your team. Your note should always include the prognosis for the crown being rendered. And then finally, we have initial and replacements. If you are replacing a crown, you need to have, as part of your clinical note and as part of the claim form, the initial placement date of that crown. So let me just pause here and share a little bit of a story. We had an instance where this was many, many, many moons ago. But the patient had a crown done, and not at our office, and came to our practice and had a brand new insurance company with no history on it whatsoever for the new year. Well, the patient wanted to have the crown done. The patient needed to have the crown done. And so we did the crown, and it was a replacement. Well, there's no history on the plan. It's a brand new plan. So one would think, right? This, again, many moons ago when we didn't know what we didn't know. Well, history doesn't necessarily stay with the carrier anymore. History is now sometimes following from carrier to carrier. In addition to, you will notice that carriers word their replacement clauses like 7 years, 7-year frequency limitation based on, I'm sorry, I'm having a brain lapse right now, but they'll phrase it so it's 7 years from the date that the crown was done, not 7 years since they paid for it, but 7 years since it was done originally. So you always want to make sure that initial replacement information is part of your note. Patient presents for initial crown number 19 due to, and now you have your diagnosis, and there it is, nice and a nice little delivery for you. Okay. The takeaway here with single tooth crowns is do not leave it up to the insurance companies to interpret your note. Make it so crystal clear that they have no choice but to pay the claim the first time. Okay. So when it comes to crowns, again, your clinical note is absolute gold. Remember, if it's not documented, it didn't happen. Your note is what tells the story. Be sure to include the reason for treatment and be detailed. Be detailed. If the tooth, again, complete cusp fracture, talk about which cusps it is. You want to give as much information as you possibly can. Include a recent pre-op PA. Bite wings or panoramic x-rays for most carriers are not substitutes for that necessary PA. And whenever possible, take photos. The phrase "a picture is worth 1,000 words" has never been more true in our industry and with dental carriers today. All right, and here we are. The last procedure of the day is going to be core buildups. This is the biggest pain point I see, whether it's denied for not being denied for medical necessity or denied as being inclusive to the crown. We see this all the time, which, by the way, if you get, there's a carrier out there that if they say it's inclusive to the crown, you just need to call and give them the seat dates. And typically that's enough to get that claim paid. Laura, I see you pop up. Did you need me?
I was just going to say, I have been seeing these inclusive of a crown so much lately, and I just want to rip my hair out.
Mm-hmm. Oh yeah. I saved this one for last because I needed everybody to stay involved here. But this was when we started talking about topics and procedures for this webinar today. Obviously, this had to be number one on the list because it's a huge pain point. And most of the time we're frustrated with their lack of payments over this. But here's the truth: the denials are common, and they usually happen for one of two reasons. The first is that the service rendered wasn't actually a core buildup, but rather restorative foundation, which we're going to talk about in a second. Or two, the documentation doesn't support the need for the procedure. Okay. So the first topic there, remember, a core buildup is not a filler to eliminate undercut, box form, or concave irregularity in preparation. If that is what you're doing, if that is the purpose for if that is the procedure you are doing, then you want to look for a different procedure called a restorative foundation for an indirect restoration. Find that in your closest coding book or reach out to me after this webinar and we'll talk about that. So if you're saying, oh, I did a core buildup because I needed, there was box form. That's not a core buildup. A core buildup is necessary for the retention of the restoration. So in this case, if we're talking about crowns, it is necessary for the retention of the crown. Your documentation should clearly state that, and then also include how much of the tooth structure was missing post-prep. So I see a lot of generics in clinical documentation here, where we will just default to 50% of tooth structure missing. And yes, a lot of requires, that's their cap. They require 50%. But if 65% is missing, then you should document 65. If 75% is missing, then you should document 75. Be specific and be precise when it comes to core buildups. Okay. Precision in your documentation can make or break a core buildup claim. Now, there are carriers, as Laura was saying, inclusivity to the crown. A lot of carriers just want to know that you did the core buildup on one date and then build the crown on the seat date. So if you're billing your core buildups and your crowns on the same date and you're not seating the crown until 3 weeks later, that could definitely be triggering why you're getting those inclusivity denials. In most cases, like I said, they want to make sure that they are getting that seat date. Laura, I see your hand up.
I am, for real, in real life. So what happens when offices have a CEREC machine and they are prepping and seating on the same day?
Great question. What do you think I'm going to say?
Hopefully we all have pictures, right? Like I'll say the office, send in photos like of the tooth before the buildup, before we put the crown on so they can see it. And we still get these, crazy inclusives, but
So, so there are some carriers that you can actually give them your CEREC machine number, and they can communicate in some way, somehow. I don't understand the technology behind it. So there are ways that you can do that. So if it's one specific carrier, you could reach out to them and ask them if they have that technology. The other is that you can actually, I would include it as part of your clinical documentation. But in the offices that I support that use CERECs or use same day milling, as the initial part of the clinical note will say patient presents for same day prep and seat of initial crown number 19. Patient, we prepped, we seated, and it's in that first chunk of it. Additionally, if you're doing it if you know that every single crown claim that you're sending out is going to be a same day crown, most practice management softwares allow you to add in a remark section. Now, remarks are like hit or miss with the carrier of whether they even read them, but you can also add remark sections in there as well. But that was a great question, Laura. Thanks for bringing that up. Appreciate that. Okay, and finally, attachment-wise, for core buildups is you want to include your PA, intraoral photos, and post-operative PAs, really big. There are carriers out there that want you to take, everyone take a deep breath, but they want you to take the after photo, like an intraoral photo of the buildup in place prior to prepping the crown. And so sometimes you need to include that. Just like we take steps in when we're doing endodontic procedures and we stop and we take the film to see, the working files, that the same thing happens with buildups. You want to make sure you take that time to document it. And again, make sure you're using the right procedure code. Okay, so I wish we had hours because if you can't tell, I'm extremely passionate about this topic. And I could probably talk about this for hours and days on end, and I'd live on this hill all day if I could. But I can't get through all of the procedures today. But if you're serious about improving your attachment game and protecting your revenue, then I highly recommend checking out our attachment recommendation guide. You can just this is completely free download for anybody who needs it. You just go to zendentalsupport.com and it's on there, and you'll be able to see what payers are requesting and the attachments that we have found to be the most comprehensive in submitting your claims. Think of it as a quick reference guide to stay one step ahead of denials, and we do our best to keep this as updated and in real time as possible. Okay. So the last couple of minutes here, I just want to talk about our audit-proof workflow, specifically because now we've talked about clinical criteria and guidelines, but how do we make it so it works for your team? So the first is this is an example of a workflow. This doesn't have to be your workflow. The point of this is that you have a workflow. Have a system in place. Systems are the foundation of your practice, and a system is only good if it's followed. So be sure that your workflow works for your office. I'm going to give you kind of just a little brief indication of what I see happen best in best practices. So for dentists, you are primarily responsible for the heavy lifting. You're answering the questions, the why. Now, Hygienist assistants, you can enter this information, but it really has to come from the doctors. Why was the extraction and the bone grafting a better option than removable partial with a planned implant placement, right? Why was a crown a better option than the filling? Answer the why questions, right? Additionally, you want to include your clinical findings as well. Your periodontal status, your tooth structure, the pathology. And then lastly, your treatment specifics. What happened during the procedure, the surgical details, the core buildup percentages, that kind of information. And then finally, you want to make sure that your note is reviewed and signed. Whether you are doing the note yourself or your clinical team members are doing the note for you with your input, your note needs to be signed and reviewed each day by you. Next, we have our assistants and our hygiene team. This is where you're going to have your clinical support, your procedure adjuncts, and your photographs and radiographs. So this is where these clinical team members are going to record measurements and charting, periodontal readings, irrigation and site-specific scaling. And you're obviously taking photographs and radiographs. Obviously, the radiographs are prescribed, but the photographs, anybody can take a photograph. I'm going to tell you the 30-second quick story. We had a patient, our new patient procedure was that when new patients came in, we did a full mouth series of photographs, just photographs, right? Before we even picked up a scaler, did any type of radiographs, anything, just photographs. And the patient called about 2 days later and says, "You chipped my front tooth." And we said, "That seems really odd." So we went back and looked, and we were able, because of that documentation, we were able to protect the practice from saying, "No, actually, it looks like your tooth was chipped when you got here." We went ahead and cleaned the area, so it probably feels a little bit more rough. But that documentation helped protect us. So just an example of how photographs can sometimes, is not just for insurance, but also for protection in the practice as well. And then last but not least, our front office team, because remember, everybody is included in this. Our front admin team, this is where you guys are the ones attaching the clinical notes, the radiographs, and the correct information. So you've got to have your audit-proof workflow designed as well in order to make sure that you're getting all the right information. Keeping updated record of periotherapies, last maintenances, and frequency limitations. Doing insurance verifications, verifying if that missing tooth clause applies to this patient, or the waiting period. Getting all that information up front will only help keep your claims more under control. So last but not least, when do we document? Here's the truth. We have fallen into an assumption that notes can be completed at the end of the day. But best practice is to truly have your note completed and all supporting documentation finalized before the patient even leaves the building. In my office, we had it done before the patient even left the chair. The doctor and the hygiene team would finish the note, they would sign it, and it would be bundled up with a pretty bow on it. Because here's what it ensures. By doing it that way, you're ensuring accuracy. The details are fresh in your mind. It helps reduce errors, and timeliness really matters when it comes to doing your clinical notes. So you want to make sure that all that is done early on. Think of documentation as part of the procedure, not something you tack on afterwards or at the end, but something that is part of the procedure itself. And I know what everyone's going to say. We don't have time for that, right? We don't have time. We're running around like chickens with our heads chopped off, and we don't have time to worry about that. But here's the deal. Good documentation does require you to take time. Not an exuberant amount of time, but just some time. So you may have to add in 5 minutes to a patient appointment just to make sure that your clinical team has the time to document and make sure their information is all there. I do recommend the use of auto notes. Make sure that you're using prompts, not scripts, because your note needs to be very patient specific. Be sure that you are including optional drop-down checkboxes. I see this a lot. We'll say reviewed medical history or updated medical history, but then there's no free text in order to indicate what was updated or what information. So use a combination of prompts and scripts, drop-downs, checkboxes, and free text. And then finally, just be professional about it. Instead of using phrases like plaque removed, be specific. Supragingival and subgingival calculus removed from upper right quadrant. Doesn't it have a beautiful ring to it? So nice. All right. At the end of the day, if you're confused by your note, the insurance company reviewing the claim is definitely going to be confused. So clear, personalized documentation protects your practice and ensures proper reimbursement. And that, my friends, is the heart of an audit-proof workflow. Clear, intentional documentation that tells the complete clinical story and protects your practice from denials and audits. Okay, Laura, I got it all into the 45 minutes. I'm going to hand it back over to you for questions and answers.
All right. I will close the poll. I know most everyone has participated. I'll share the results. I think everyone should be able to, can everyone see the results?
Ooh, yeah. Which part of the insurance?
So which part of the insurance process causes your team the most stress? So the majority of the answer was dealing with the missing information requests. And sometimes, so I will say, question on the side of this. So if the missing information they're looking for wasn't captured during the patient visit, how can office best navigate that situation?
Great question. So some carriers will allow you to just call in and provide the information. So, and generally it will, and if it wasn't captured, you may have to reach back out to your patient. So I just had an instance, we have a carrier that is retroactively, now they paid for the post and course, they paid for the crowns, but they're retroactively now requesting money back for post and course that were paid 2 years ago because they don't have dates of the completed root canals. And so I know, everybody take a deep breath, Everybody's just went, what? So what we have to do now is we have to go back to the patient because the patient came to us with those root canals already completed. We have to go back to the patient, ask him, when were your lower anteriors root canals? Give me an estimate, give me an idea of who did them. We have to go chase that information. And then we have to go back to the carrier and say, hold on a second, we're not sending money back. We're going to keep the money you paid because you paid a legitimate claim. But here's the information that you need. So sometimes it does require us to go back and get information, but that does give me a good 30-second point here. If we're doing our complete comprehensive exams on our new patient visits, the majority of those comprehensive exams include charting existing dental services and existing dental work. I encourage it to just be part of that process. Patient has a crown and a root canal in tooth number 19. The first thing I'm going to ask is, how long ago was that root canal done? How long ago did you have that crown done? Now, I know a lot of people are going to say patients don't know. They don't have the answers. You can get estimates from your patients. Listen, I remember I was working for Joe Schmo in 1982 when I had this crown done. Well, guess what? Then we know the crown is, well, how long ago is 1982? 40 years now? Oh my. So we know that the crown is over 40 years old. Some, specific things like that can matter. So to kind of circle back to the original question, sometimes it does force you to go get the missing information and then either contact the carrier and give them that information, or sometimes it's just a matter of printing out that EOB, taking a screenshot of the clinical note that has the information and sending it back into the carrier. You can do that too. But just getting that information to them is going to be the top priority.
Right. Very close second at 42% was gathering the supporting documentation. Now, I know we talked about doing it while, clinically in the area. So one of the questions was going to be, how can we get the teams to support the necessity without adding a lot of time to their appointment or kind of getting them into the habit of gathering the things that we need to best support any claim that we have from the beginning?
Absolutely. Great question. I think it comes down to education. People who are confident in understanding why something's needed are going to be much more apt to understand and get the information that's needed. So I would start with downloading that attachment recommendation guideline. Have that in every single operatory. So if you have a patient that has been diagnosed with stage 3 periodontal, grade C progression, we know that we're going to need XYZ for these in order to submit the claim, and make sure that that is right in front of your clinicians. So that way they know exactly what needs to document. But I'll be honest with you, a lot of times it's just lack of education. The insurance guidelines are changing so much. Like I said, 10 years ago, I could submit a claim for scaling and root planing and a pano and a perio chart, and It was beautiful. But now they require that everything has to have your why and that supporting documentation. And if you don't stay abreast of the information, then it just, and by taking webinars like this and reaching out and getting that knowledge, that's the only way to stay on top of it.
I love that. I always want to get them in the habit of like using the tools, do the things.
Oh, absolutely. You know, and it's like when your documentation is all in line, I mean, I see this. We often start with clients who don't have the greatest documentation. So we work with them to get them to a place. And you'd be amazed by how just simple changing templates, changing your prompts and your clinical notes can just change the way an insurance company reads that narrative.
Right. So I was looking at our survey. It looks like 68% of the people who responded use like an auto note or a template to kind of get everything, standardized as far as their note and get everything done. Looks like the doctor does the majority of everyone's clinical narratives for procedures, which is great. And then it looks like most people, as far as their, additional requests, most people are less than 5 who answered, which is great per week.
That's awesome.
Some people are kind of in the middle at like 6 to 15. It was about 30%, and only a handful had a lot, like 15%. Yeah. Reach out, download the resource.
Please.
And then it looks like intraoral photos were split between always and sometimes. And I guess, even for myself, it kind of depends on what we're doing. But, if we have them, I like to send them. You can't dispute if I took a picture, you see it. Don't tell me, because some things you can't see on an x-ray. If someone has a crack, you can't always see it on the x-ray.
Yep.
So,
photos, people, and use an intraoral camera. I had tried to avoid using, using cell phones. That's, if you want to use an intraoral camera, document it and see some offices have big iPads that they can use to document and take photographs. But the intraoral photos, reach out to your supplier and get one of those, get a good one, because it can be the different. I mean, honestly, I have seen claims that go with a picture and without a picture, and the ones that go with a picture always get paid a lot faster.
Yes, I will. Oh, what happened to me? Where did I go? I'm back. Yes, I will say those, photos you can't dispute. I will say that.
Definitely not.
I love them. So I looked in our Q&A box. I feel everyone said, what a great job. I don't think anyone has any questions. I do love everything. And I feel like I could talk about all these things for a long time.
All the time. All the time.
Talk about all the things and all the crazy new denials that I get. And I'm like, is a real person reading this claim or a bot? Who is really reading this? I gave you all the information, but that's probably a day for a whole nother conversation.
We could talk AI for a whole nother 2 hours.
Yes, and insurance. So I did want to thank everyone who joined us, and thank you for giving us such great presentation and taking, the insurance headache and turning it into like very clear, actionable little roadmap for everyone who's involved. And, I wanted to make sure if anyone has any questions or wants to reach out to Alyssa, they can reach her at zendentalsupport.com. There's a download on there for you that she shared also. Do you have any final parting thoughts before we sign off? I know we just have a few minutes left.
Yeah. So let me just end with this. So at the end of the day, clinical criteria and documentation are not about pleasing insurance companies. It feels that way, right? It feels like we sometimes have to do all of this just to get a claim paid. But the truth is, the documentation is about protecting the integrity of your diagnosis. It's about defending the care you believe in and ensuring that your patients receive the necessary treatment they need without unnecessary barriers. Here's the truth, and everyone take a deep breath. Insurance companies don't actually determine the necessity. You do. Your documentation just proves it. So when you master that, you stop reacting to denials and you start leading with more confidence and control. And I think that is the difference between surviving insurance and mastering it. Thank you all. I appreciate this so much. This has been amazing. Thank you to everybody who has joined today and your engagement. And thank you to Code. Thank you to Laura and Daniel. This has been such an amazing opportunity. I am so honored to get to share insights like this with a group that is committed to dental excellence. So thank you. Thank you for having me. And if anybody has any questions, please don't hesitate to reach out.
Yes. Thank you, Alyssa. I loved it.
Absolutely.
I know everyone, I was reading all the chat boxes over here. It sounds like they did too. So I wanted to thank everyone again. We'll see you at the next Code event. We do have the Inner Circle coming up in about 2 weeks on March 17th. I will be hosting Lucas Martin of Great Dental Websites. We have the Mastermind coming up. That is on March the 19th with Bev Wilburn and Zach Shelley. We're celebrating his 2 years of Dental Office Management Leadership Network. And we have the Code Live event that'll be happening April 17th at National Harbor. We have Rick Garofalo, Andre Shearden, Malika Azargoon, and Zach Shelley. So come see us. Alyssa will be there too, right?
I will.
She'll be there too. Everyone can stop in and say hello. And I hope everyone has a great afternoon. And I'll see you all again. Bye, everyone.
Bye, everyone.